Okay, so hi everyone, and welcome to the Calgary Neuropathy Association. I'm Linda Pettio, your host today and the president of the association. With us today also is Louise Jones-Moore, also a member of our board. So let's get started. Today we have two practitioners from Neurvana Naturopathic Medicine talking about neurofeedback, neuromodulation, and photo-biomodulation technologies for approaching a selection of challenges. We have Corey Deacon, who is a certified functional medicine practitioner. Corey is certified in holistic health by the American Association of Drugless Practitioners and in alternative medicine from the American Alternative Medical Association, with experience in the fields of neuroscience, neurophysiology, biochemistry, genetics, medical sciences, pharmacology, cognitive, I had a brain fart on that one, cognitive neuroscience, medical science, biomedical sciences, and natural health. He also has board certifications in anti-aging, regenerative, and functional medicine through the A4M, and in neurofeedback through the BCIA, where he is also an associate fellow and certified mentor. And we have Dr. Ryan Best, naturopathic doctor. Dr. Best is a registered member of the Oncology Association of Naturopathic Physicians. Dr. Best focuses his practice on integrative cancer care, autoimmune diseases, and allergic disorders. He has extensive training in chronic infectious disease management and therapies, as well as thorough training in mast cell disorders. Okay, with that, I'm going to pass it on to you two fellows. Thanks very much for being here today.
Amazing. Thank you for having us. All right. So we're going to discuss with you guys today some technologies and approaches that we use at our clinic to work with conditions like peripheral and centralized neuropathies. Oh, if I can get my slides to work here. There we go. So as most of you probably know, these conditions are a very wide spectrum of presentation and causes. So the healing journey, I like to say, is an N=1 experience. This means the subject is you. Every single person is a little bit different in terms of the microenvironment that drives these conditions, the underlying causes that are contributing, and our response to the condition. And I'm going to talk a little bit more about that. So those of you that have been on this journey, and the healing journey like myself, know that it's not a linear movement. It's cycling all over the place sometimes, it seems. So we like to the approach that we take is to help refine this and help guide with this with more precision. So I like to say a healer does not heal you. A healer is someone who holds space for you while you awaken your inner healer so that you may heal yourself. So what we're going to talk more about today is prior to talking about the techniques of neurofeedback and photo-biomodulation is more how do these things manifest? What sort of underlies them? And we want to share some of the clinical background and clinical data that we have on kind of how this all comes together. So the common types of peripheral neuropathy are diabetic neuropathy, inflammatory neuropathy, injury-related neuropathy, where an injury occurs and we either struggle to or cannot repair the nerve function. There's drug-induced neuropathy, which you typically see with chemotherapeutics, environmental toxins as well. We also add in stroke-induced and neurodegenerative induced, which is actually more of a centralized neuropathy. So it's more related to the brain itself, typically, but it does result in symptoms of peripheral neuropathy. And then the last one is idiopathic, which is, we don't know why it's happening. And a lot of times these are the neuropathies that don't come back clear on nerve conduction studies. And I used to have a professor in college who said idiopathic means I'm an idiot, I can't figure it out. So we like to try to fill in those gaps because we do see, especially with regards to the inflammatory neuropathy, where it actually is idiopathic. It doesn't appear to be inflammatory through conventional labs and conventional measurements, but when we look a little bit deeper, we indeed do see that there is some low-grade chronic inflammatory responses going on. And this is also sometimes related to what Dr. Best actually specializes in, and he'll talk a little bit more about this, autoimmune responses and infection. And infection is not always what we think. We sometimes think that acute infections are the only way to get these symptoms, when a lot of times there's actually low-grade chronic latent activated infections that don't look clearly like an infection that may hospitalize us or, require IV antibiotics. So we'll go a little bit more in depth on that today. And some other items that we want to capture as well is the comorbidities or other conditions and symptoms that tend to come with the peripheral neuropathy. And I know that a lot of patients that I work with, the neuropathy is not even their major concern when they come to see me. Usually the major concerns are some of the emotional distress, anxiety, depression, fatigue, pain, other chronic pain, insomnia, and cognitive dysfunction that do sometimes come with that. So I'm going to walk you through kind of what underlies that. So the main take-home message for any condition, really, in the way the lens that we look through, is that something has caused the stress tank to overflow. So you think of our body, our nervous system is like it has this tank of stress that it can hold stress in, and it can hold and hold and hold and hold different stressors until it overflows. And these stressors can be environmental, they can be physical, they can be inflammatory, they can be toxic, they can be mental stress. A lot of times people think of stress as mental, but there's a lot of different types of stress that can all be additive in the system. And as soon as that tank overflows, that may be an injury, it may be an infection, it may be something unknown. All of a sudden, one day, it's like the straw that breaks the camel's back. And all of a sudden, we're stuck in this response that we can't get out of. And this is where our clinical conditions can emerge from. This always occurs from a place of fight or flight response being turned on for too long. So I'm sure some of you have heard of the fight or flight and the rest and digest state. The fight or flight state is not bad. We're just not meant to be in it all the time. So we actually need a fight or flight state to even deliver oxygen to our tissues when we breathe in. But if we get stuck in that chronic state, our body cannot engage the healing response. And the innate healing response within the body is the most profound. We can't mimic it. We can help guide it, and we can help get things out of the way that shouldn't be there, that are putting stress on or keeping the body stuck in the fight or flight. But the best healing response is actually getting our own nervous system into the rest and digest, or the healing state. So the subtypes that we tend to see in neuropathy, we break them down more functionally. So rather than, calling it diabetic or autoimmune or toxic, or we kind of see the fallout of these 5 different subtypes. So the first one is inflammatory, which includes autoimmune. This is where the fire in the body builds up too much. The immune system may be getting stuck in an inflammatory response and not regulating properly. And then we have infectious, which is more viral, bacterial, fungal, and parasitic infections. These can be systemic. They can also be in the GI tract or in the sinus cavity. And these are going to create, the inflammatory and the infectious kind of intertwine a lot because the inflammatory response of the body is trying to fight an infection, and it may do that for years and years and years and years and years and not really ever be able to get ahead of it. And then we have the metabolic subtype. which relates to a cellular structure called mitochondria, which most of you might have heard of, maybe from high school biology, the powerhouse of the cell. So sometimes we can get ourselves into metabolic dysfunction where we're not regulating our energy resource availability. And one thing that can suffer from that is our peripheral nerve endings. And then we have trauma responses. So this is more of a limbic system related issue. I have in there emotional. It doesn't always come with emotions, but trauma responses that stay stuck on for too long, which we'll go into a little bit more detail as I go here, can keep us stuck in this cycle. And then dopamine and memory related issues, which is more the mental and belief system structures that are formed. This is more the cognitive basis. So, do we believe that we can get better? Do we believe that we can find the state of peace that we know in our heart is our true nature? Or are we really stuck in the self-limiting beliefs that, this is what I've been given, and then this is all, this is basically where I'm going to be stuck. So one thing that we sort of work with in conjunction with neurofeedback is something called quantitative EEG, and I call this my North Star. It's a way for us to look at the brain and the nervous system and figure out kind of where it's at, where the bigger stress points are within the system, because there are all these different subtypes that can be contributing to the disorder. So quantitative EEG is kind of this cool cap that we put on, and we pick up electrical activity from the brain. So it's a functional analysis of the brain. Unfortunately, you don't get to drive the fancy convertible, but you do get to have the fancy cap on. And what we're doing is we're picking your brainwave activity up in live time, and we're getting an idea of what the baseline state of your brain is, which tells us where it's being stressed and how it's compensating for that stress. So we have these different brain waves. All of them are linked to different cortical and subcortical functions. We can get ideas of how the inflammatory immune system's regulating. We can see how the emotional and the limbic systems are regulating. We can see the metabolic system. So it's a little bit like the nervous system talks to us if we have the ability to assess it and understand it. So this is kind of what a quantitative EEG map looks like. There are these colored maps that show up with lines. Ideally, this is what you sort of want to see when you look at a map. Most people we see have a lot more color. There's a lot more blue, there's a lot more red, there's a lot more orange, there's more red and blue lines. This is all showing us where the brain is either not wanting to express a certain frequency or it's overexpressing certain frequencies. Depending on the area that this is happening in, we can get centralized problems with sensation, with pain, and it also gives us insights into kind of what the subtypes are that we need to be looking at for conditions like neuropathies. We also have the ability to see deeper down in the brain. And again, this really helps us understand where somebody's at, not where, neuropathy is, but where you are at with regards to the condition of neuropathy. So digging a little bit more into the causes. So inflammatory causes, we see these are various different things that we see that contribute to inflammatory type neuropathies. So food allergies and sensitivities, microbiome imbalances where the bacteria and the microbes of the gut are out of balance. So it's not important that you know exactly what bacteria and what parasites and all that, but just know that when there's an imbalance in the gut microflora, there's a risk for inflammatory activation. Then we have toxin exposure, heavy metals, environmental toxins, mold, medications, as we discussed earlier, infections, and autoimmune responses. This is how it shows up on a brain map. So oftentimes what you'll see with the inflammatory subtype is there'll be a lot of slowing of brain waves. So delta, theta are the common ones, brain waves that show up. Over this person, you'll see over the central area here on the left and the right is right over top of the somatosensory areas and the insula. So when that area goes more asleep than it is awake, this is exactly what you'll see with neuropathy. It's like those parts of the body that are supposed to be encoding sensory information are going more asleep. And this is just an example of how the gut microbiome, when it's dysregulated, can lead to inflammatory output from the immune system, which can start affecting peripheral nerves, cranial nerves like the vagus nerve, which means people can start getting digestive concerns as well with these. And then that can actually lead to neuroinflammation, which can affect cognition, mood regulation, sleep, and other things are associated with the brain. Dr. Bess, I'm going to let you chat about post-Lyme piece.
Yeah, yeah. So post Lyme syndrome, a lot of people, it's come up in the news. A lot of people are aware of the fact that Lyme disease is now not only kind of an accepted diagnosis, but it's also a diagnosis that's becoming kind of its own epidemic. Lyme disease has become more and more common over the last couple of decades. There's more and more patients, especially in Western Canada, being diagnosed with this disease. But like Corey was mentioning before, one of the big issues is that we have this idea that the infection, when you have the infection, it's simply about identifying that infection, using antimicrobials to wipe it out, and then all the problems go away. But what we see, and what most clinicians who work in these kind of advanced practices see on our day-to-day patient loads, is that people that end up diagnosed with Lyme disease, often the problem is not the bacterial infection anymore. We clear that bacterial infection, and yet patients are left with these really difficult, what we call post-Lyme syndrome situations, or what we also call chronic Lyme disease. You'll hear that. And that's when we see neuropathy with Lyme disease, what's typically happening is that even after the infection is cleared, for some patients, for some poorly understood reasons, their immune system stays kind of elevated, acting more aggressively. Even though the infection has been removed, the immune system should be calming itself down, but instead it's like the gas pedal kind of stays stuck on, and the immune system can start to find other healthy targets like nerve cells and start to create problems with them, like the bacteria is still present. And so that's where we can often see these neuropathy situations, different types of nerve paresthesias, abnormal sensory changes, burning pains that can show up, numbness and weak tingling in some areas, and then other defects like cognition, joint pain, and other ones. So post-Lyme is the most famous of these types of what we would call infectious related neuropathies, but this can actually happen with a lot of different chronic infections after the infection has been cleared.
Mm-hmm. And you're also seeing it with post-COVID as well.
Yeah,
and I think
big area we've seen a lot of.
Yeah, and this bridges into something that I specialize in called chronic inflammatory response syndrome. And so one of the functions that we do understand when people get a high exposure to biotoxic material from infections or from like water damaged buildings is there's a leptin receptor that is a receptor for a hormone called leptin that kind of it's throughout the body, but when it gets damaged at the level of the brain at one of the master glands called the hypothalamus, it causes all of these different systems to get thrown out of whack. And one of the big pieces is that the T regulatory cell system crashes out. Now we can't regulate the different components of the immune system appropriately. So sometimes you'll see autoimmunity activate. Most of the time you'll see the innate inflammatory immune system, which only really knows how to start everything on fire, and it can get stuck on. And this can lead to all sorts of hormone changes, serotonin and dopamine disturbances, which is oftentimes associated with anxiety, depression, and cognitive dysfunction. And then, with cortisol crashing and mitochondrial problems, we get fatigue. So this is something that we do very commonly see in these inflammatory infectious profiles. So metabolic causes. So the metabolic causes contributing factors have to do with typically mitochondria dysfunction. Now, there's different ways that this can occur, but basically the body stops producing energy in the same efficient manner that it normally can, or something is impairing its ability to do that, like you see with insulin resistance or what we call leptin resistance. We see it with nature deficiency syndrome, I call it, which is basically not getting enough sunlight, too much LED light exposure. This actually impairs the ability for the mitochondria to repair themselves. So they start becoming damaged and they can't make energy properly. And then EMF exposure, which is, again, another new kid on the block that's being shown to cause problems with calcium signaling in mitochondria, and why I think we do see some of the neuropathies and idiopathic numbness and tingling stuff has been on the rise in the last decade or two. So mitochondria are the powerhouse of the cell, if you, again, recall from biology. However, they're doing a lot more than that. They actually regulate the cell behavior. So they play a big role in telling our cells what to do and when to do it. They derive from ancient bacteria, a bacteria that was found to be about 3.6 billion years old. And at some point in the process of evolution, they integrated into an animal cell. And in that process, they allowed this symbiotic relationship occurred that allowed multicellular organisms to build. So we would not be able to build the human body in all of its complexity without mitochondria. Now, when you look at brain maps of people that have mitochondrial dysfunction, you're going to tend to see an alpha increase, either in the prefrontal frontal area or kind of throughout the brain. A lot of times you'll see brain fog and fatigue come with this subtype. But the biggest thing with this, what I want people to understand, is that the mitochondria are like a windmill. They're like a generator. So if we can't generate enough energy resources, we can't repair. So if we've had something that has led to the development of neuropathy, if that's an injury or an infection or an autoimmune response, and as Dr. Best said, like, we've gotten it under control, right, or the injury is no longer happening, but we don't have the energy resources to be able to repair, then we're going to get stuck. We're going to get stuck in the cycle of the symptoms of neuropathy. So there's actually some really good research on this. Mitochondrial diseases, mitochondrial dysfunction driving peripheral neuropathies. The circadian rhythm also plays a role. I think for the basis of time, I'm going to breeze over this, but the circadian rhythm is something that is regulating the timing of everything in the body. And our gene expression behavior requires what are called clock genes to input their information. So it basically is telling the cells what time of day it is. The important part of this is that if our sleep is dysregulated, if our light exposure is dysregulated, if our meal timing or exercise timing is off, it can drive these metabolic problems. So sometimes there's very easy lifestyle things that you can shift to drive this. And then again, another thing I'm not going to go into a lot of detail on because it could be a whole presentation in itself, but ketosis and fasting, very effective ways to help the mitochondria recover. And some of the acids that are produced from fasting and ketosis can actually lead to regeneration of mitochondria and regeneration of synapses and nerve growth factors. So something you always want to do under the supervision of a doctor, but very, very effective approaches. Now, the emotional limbic causes, this can be things like PTSD, unprocessed, unintegrated incidental trauma. And I call this incidental trauma, meaning that an incident occurred and we weren't able to reconcile it when it was happening. So this is sometimes people that have sudden onset peripheral neuropathy, or they had a severe injury or accident that actually was traumatic. And anytime that we have a change in our body state, there's a potential for quote unquote trauma. And so when this happens, we can get stuck in a loop of the limbic system feeling like it's under threat all the time, right? So the symptom is equated to a memory and is equated to a program that is calling it a threat. And what you'll see in the brain map is the elevation of this frequency called theta, which means that the limbic system is hijacking certain parts of the brain, and it can also hijack parts of the body as well. The loop of this is that as the amygdala and the limbic system fires more and hijacks more, it actually causes us to get more oxidative stress and dysregulates the immune system more. It also causes low-grade inflammation in the brain, which actually increases the likelihood that a threat response is going to happen again. So we really get stuck in this vicious circle, this vicious loop where we keep inflaming ourselves. And we can go look for the next therapy and the next anti-inflammatory agent and the next this and the next that. But unless we deal with what's happening within us, we're not going to be able to get that threat response under control. So it's really important to understand if this subtype's happening, because that's where you want to put your attention. That's where you want to put your dopamine resources, is to work through that. That's going to give you the best bang for your buck if you're in that subtype. And we're going to talk about neurofeedback in relation to this in a moment. And then this bridges into the mental side, the cognitive side, which mainly associates with dopamine. And so dopamine is basically associated with everything outside of the here and now. So if I want to change something about the current moment, I'm going to start releasing dopamine, right? So this may be like, I really want an ice cream. As soon as I start thinking about the ice cream, I start releasing dopamine. And then I'm going to start moving towards going to get the ice cream. I'm going to walk inside. I go inside and I realize, I'm out of ice cream. Okay, now I got to release more dopamine because I got to get in my car and I got to drive and I got to go get ice cream. When I get the ice cream, I no longer need dopamine. My dopamine starts going away. Now, if the ice cream meets my expectations of reality, I'm going to get a double hit of dopamine and I'm going to feel pretty good. If the ice cream is like the Central American ice cream that I just came back from eating, and it's not matching the North American ice cream that I expected, I get a removal of dopamine and I start getting a crashing out effect. And so what happens is that we can start running these dopamine programs where I don't feel good. I need to find something to help me feel better. And the greater the need is to feel better, the more dopamine that I have to output. Now, this is fine, except for the fact that dopamine is a currency. So as soon as I push out a whole bunch of dopamine, I'm going to get a dopamine crash. Then I'm going to have to go into this lull period before I come back up to baseline again. If I don't allow myself to come up to baseline again, and I keep trying to get my dopamine back up above baseline, I'm going to keep digging myself a deeper and deeper and deeper hole. So in these subtypes where we've burnt out our dopamine, generally we're really fatigued. Generally we're bouncing between anxiety and depression. And what actually ends up happening is we can't shut off something called the inflammasome properly. So we actually start inflaming. So when we have enough dopamine around, we can regulate inflammation. When we don't, we shut off the ability to regulate that inflammation and we get stuck again in this inflammatory loop. And what you'll see in people in brain mapping is the prefrontal delta will actually crash out when they're in these states. So again, this is part of kind of physically resetting dopamine, overlaps a lot with mitochondria function. And two of the best things that we have for this, as well as the emotional subtype, is photo-biomodulation and neurotherapy, or what we call neurofeedback. So neurofeedback is actually a process where we can pick up the brainwave activity in live time, and we can figure out where there's excess amounts of brainwaves or where there's not enough brainwaves, where we're still stuck in a trauma state, where we're still stuck in a dopamine burnout cycle. And we can actually move and train the brain into a place where it's not running that same pattern, that same program that it's used to. So as the program functions, you may be watching a video game or playing a video game with your brain. You may be watching a movie, listening to music. When your brain is doing what we want it to do, it's going to get feedback. When it's not, the feedback cuts out. And so what the brain is going to do is it starts getting rid of the neural patterns that it's not getting feedback from, and it starts wiring in the patterns where it is getting feedback. And so with time, you can train the brain out of these centralized trauma and dopamine loops, and it allows the brain to reorganize itself in a way where we get to a solid baseline and we're not in that fight or flight state anymore. I'm just going to skip here to, and then I want Dr. Best to kind of take it away with the photo-biomodulation.
Thanks, Corey. Yeah, so as Corey, just to reiterate something that we see as really important in basically the understanding and how we create treatment protocols for patients. Most people who are tuning into this talk today have some form of neuropathy that we've already spoken about. But what's so important in assessment of the patient, like Corey mentioned, is this idea of trying to look at each patient as an individual. You are different than any other neuropathy patient that's come into our office. And so what we're trying to look at is not just, what's the diagnosis, which may be, Charcot-Marie tooth disease or small fiber neuropathy. Those are telling us about a process, but they don't tell us everything about the patient. We need to see what else is going on for you. What kind of contributing factors could be part of the cause or part of the propagation or worsening of these diseases? Because Corey and I could tell you hundreds of stories that back this up, where the best results that we see for patients is when we look under the hood, we find all of those contributing factors, and we design protocols to go after everything. We're going to use fancy therapeutics, things like neurofeedback and laser therapy, to treat the damaged tissue, absolutely, but we're not going to stop there. We're going to look at everything else that's kind of going into these factors. That's why individualized care is becoming such an important tool in our healthcare system, because it's something that's kind of missing a lot. Now, photo-biomodulation, the more common term you'll see for this is something called low-level laser therapy. This is basically the use of high-intensity red and infrared lasers. These are not cutting lasers. They don't produce high levels of heat like you might get for, laser eye surgery or a surgical correction of a skin disorder, removal of a mole, things like that. These produce some heat, typically a warmth, but they have very interesting physiological effects on any tissue that they're applied to. And you'll see on the next couple of slides here what those devices look like. So we can pop over to the next slide there, Corey. So this is actually a photo of the arrays. You'll see this on the next slide after this as well. This is what's called a BioFlex device. This is the medical device that I supervise here in the clinic. And what you can see there is you can see that kind of glow. This is a flexible array that can be conformed and wrapped around any tissue of the body. So it can be put around a shoulder, an arm, a knee, an elbow. We'll wrap it commonly over top of areas of neuropathy, like the feet or the hands, which are very common areas for neuropathy to develop. And you can see that kind of soft glow that's happening underneath that. That's in the red phase of treatment. So the red phase, you can see. The infrared phase of the therapy you actually can't see. And these are applied over top of damaged tissue, either centrally in the central nervous system or peripherally in rest of the parts of the body that are actually experiencing the neuropathy itself. So we can flip forwards there a couple of slides. You can see another example there of the shoulder. This is the clinical effects of the laser therapy itself. So what the laser therapy, what high intensity or low level laser therapy does from a physiological mechanism, I'll leave this up. I won't go into every detail on this. The major effects that laser therapy offers, why it's useful for conditions like neuropathy, but actually a host of other conditions, including musculoskeletal injuries. It's part of our standard of care process for post-concussive syndrome, has several large clinical trials on that. We use it with neurofeedback in combination, several other types of dermatological conditions and others. But in this case, for this talk for neuropathy, it has three major effects. The first thing is something you'll see in that top left corner there, which is what's called angiogenesis and neovascularization. Fancy, confusing medical words for basically meaning forming new blood vessels and getting more blood to a damaged tissue. What happens in most forms of neuropathy, whether it's diabetic neuropathy, where high blood sugar has caused damage to nerve endings, or chemotherapy-induced peripheral neuropathy, where the chemotherapy agent has damaged nerve endings. What happens in a lot of these processes, inflammation can do this as well, is it damages the small blood vessels in those areas. If you don't have enough blood flow to a tissue, you can't get oxygen, you can't get nutrients into that area, you can't remove waste products. So you need better blood flow to a tissue for nerves to be able to heal. Laser therapy is very good and has very large clinical trials showing that it is a very potent stimulator of new blood vessel growth. Second thing that it does is it is a direct anti-inflammatory. So this really comes into play in situations like the inflammatory neuropathies and the post-infectious neuropathies. This is a really important healing tool, and also in our post-concussive syndrome patients as well. This causes, when it's applied directly to a tissue, a very drastic reduction in inflammatory signaling inside that area that can be long-lived. So the difference between the laser therapy, we'll talk a little bit about timing and long-term use, but one of the big benefits with the photobiomodulation or laser therapy is that often we can do short courses of therapy that then have long-lasting results in that tissue. When you've built up new blood vessels, removed some of those inflammatory signals and healed some of the damaged tissue, you often don't have to keep retreating it like a lot of the medications that for anti-inflammatories that you have to take every day, sometimes multiple times per day. Same thing with nerve blocking agents like gabapentin and Lyrica. Those are daily, multiple times a day use. Laser and neurofeedback have some advantages that when they can heal the damaged tissue, the body's capable of functioning more effectively on its own. It doesn't necessarily require long-term intervention. That's always a major goal for us when we can for treating our patients. The last piece, the bottom line, I won't go too much into more detail for time's sake, but this can directly stimulate nerve repair in that tissue. It stimulates what's called nerve growth factor release. Yeah, if anybody wants to really nerd out on that stuff, we can send some papers after today's talks and share that. But it's a pretty cool mechanism for what it can do for stimulating nerve repair and growth directly. So we can move on from there. So a little bit of background just with the laser therapy device. There's been over 1,400 randomized controlled clinical trials that have been completed with the low-level laser therapy intervention for, like I said, a variety of conditions, of which over 60 of those trials have been done in peripheral neuropathy-related conditions. So really well-researched therapy. It's used really commonly, actually, in the United States in a lot of comprehensive medical centers down there. The reason we don't see it adopted as commonly in Canada is the devices are expensive, so our public healthcare system often doesn't really want to kind of foot the bill for those devices, and it's not as easy as a pill, right? We our medical system loves medications because there's no application time. You don't need a technician to run it. You give someone a script, you send them home. Nobody has to supervise that, right? You can just give them a pill and send them on their way. These therapies, there's a lot more intervention required for them, so they don't fit our medical model quite as well. But these therapies, what you'll see, and you've seen this with Corey's talk a lot as well, is we don't typically take single approaches to care going forward. We'll typically take a combination approach once we know a lot about that patient's condition and the patient themselves, and we can combine things like laser therapy with treatments like neurofeedback when there's mental health components, mitochondrial problems, central pain processing issues, dopamine and hormone signaling neurotransmitter issues. We'll use these together. We'll tag these treatments better together because they get better results when we use them in combination sequence. Same thing for things like other anti-inflammatory therapies, oral and otherwise. We can use therapies that stimulate neurological repair, neurogenesis directly. We can use regenerative injection techniques. We have an excellent sports medicine doctor, regenerative injection specialist in our clinic as well. And we'll combine that with things like perineural therapy to reset nerve signaling, or prolotherapy to heal up damaged tissues. That's really kind of a basic list of where we can start with those combinations.
Peptide therapies, I think, is another one that's been,
Yeah, really interesting. Peptides is a large field, something that a lot of people are coming across in their reading now. Peptides are a really interesting and frankly pretty useful approach to certain types of disease conditions, and those can be combined into practice as well. So with the treatments, this is kind of a, consider this a rough estimate. This is, a ballpark for a lot of people, but most people, we're typically going to be putting them through a couple of months of therapy with these approaches. That's typically true with laser therapy as well as neurofeedback and some of the other treatments that we'll do. Some conditions require longer, more long-standing severe conditions sometimes can require several months of therapy. More acute conditions, sometimes quicker conditions or more acute conditions can sometimes even be less than this. We can see very significant results in as little as 3 to 4 weeks for some people. Often these treatments will be done anywhere from 1 to 3 times per week, again, depending on multiple factors that go into that. And the sessions take anywhere from 20 minutes for small areas that we're treating. Maybe the injury is just, an injury to a hand. That's going to usually have patients in and out pretty quickly. Larger areas that have been affected by some of these diseases or neuropathies, the time goes up basically by the amount of tissue that's needed to be treated for those. So 20 to 60 minutes is typically typical. Now, these conditions, what's exciting, like I mentioned before, is that things like laser therapy and some other treatments like neurofeedback, when we're successful, often we can get not only symptom improvements in 4 to 8 weeks of therapy. In some cases, we've had complete resolution of those symptoms, depending on the disease or disorder that's present. And the better part of that is that doesn't require continuous long-term management. Those are the patients, and I always make a joke for my patients that I love seeing them, but what I really love seeing is I don't see them very often at all anymore. I get a Christmas card from them once a year and they say, thanks again for the help. I'm doing awesome. That's really what we're aiming for with these types of treatment protocols. Side effects are pretty mild with this therapy. Typically, there is no serious documented negative adverse events with the laser therapy approach. That is also backed up in the neurofeedback literature as well. So the safety data is excellent. When we have side effects, they're typically what we would call transient or short-term side effects, and they can fluctuate anything from skin irritation, which we can deal with over-the-counter therapies, sometimes transient changes to neurological sensation. This is an odd thing with a lot of treatments in this realm, where we have a saying with neurological treatments or neuropathy treatments that the first couple of treatment sessions, any change that happens is typically considered a good thing, because it's a sign that the nerves are starting to try and do something different. They're trying to heal. But nerves can go through these strange cascades of recovery where, let's say you come in and you're actually primarily struggling with burning pain in maybe at the bottoms of your feet or in your hands. We start treatment, and the first couple of weeks, you may notice that the burning pain starts to come down, but now you've got an odd tingling sensation in that area, or you've got a little bit of numbness that's fluctuating in and out of that area that you didn't have before. That's a sign that the nerves are kind of moving on a recovery cascade. And over the next couple of weeks of treatment, that will also start to go away. But as the nerves try to heal, they send what's called aberrant signals. They can send abnormal firing patterns, and that's not a bad thing. It's a sign that the nerves are on their way to recovery. When we get towards the later stages of protocols, basically no one is left with those residual issues. I think we're back.
Sorry about that.
Oh, good. So the side effects, like I said, the bottom line with it, pretty transient. Almost everyone gets through them with absolutely no long-term issues. We have great therapies we can use to intervene if there is any temporary side effects, but 50 to 60% of patients actually start these treatments and they have nothing but positive results coming through that. So that's always a nice thing in medicine, low risk to these therapies as well. Last thing about therapeutics, this is in one other device, and I won't go too much into this, but this is something we use quite commonly in our comprehensive care protocols. This is something called intravenous laser therapy or IV photodynamic therapy. This is a newer therapy that's come out in the last decade. It's been used pretty extensively in Europe and down in the United States. We're one of the first few clinics in Canada to bring this in. And what this therapy does is this is specifically useful in the neuropathy world. This is a very effective way to go after systemic inflammatory signaling and systemic infectious problems, as well as mitochondrial disorders. There's complex mechanisms at play with this device, but this can directly hit white blood cells, inflammatory signals that are circulating around in the bloodstream. And this is one of our go-to tools that we'll use to manage people who have things like autoimmune or inflammatory diseases that may be causing part of their neuropathy, or they have mitochondrial disorders that are causing peripheral pain syndromes, fibromyalgia, fatigue issues, or also again related to neuropathy. So we can use this as part of kind of a complex treatment protocol that will go with it. Side effects again are usually very good with this, a little bit more nuance to this therapy, but that's another department that I kind of head for our clinic and a very useful tool when we can bring it in for complex care. And you'll see the next few slides. These are just a few different of the hundreds of clinical trials that have been done on photobiomodulation or laser therapies for these different types of disorders. If anyone is medically literate and likes to read any of this literature, again, we can get in touch with the coordinators for this talk and be happy to share some of that research if anybody wants to read through that as well. So we can flick through a few of those slides, Corey. And then we'll kind of pop down to the bottom here. So Corey, if you want to take over the last little bit.
Perfect. So yeah, I mean, these will just make sure these are captured in the video. It's pretty easy to pop on Google Scholar, PubMed, and lots and lots of research on this stuff. Scroll. So I think one thing that I want to just capture is that any neuropathy, peripheral or centralized or otherwise, it's complex. Like, we're very complex beings, you know, pathogenesis of disease states is very complex. There's a lot going on. You know, we're a biophysics organism, so, you know, there's biology and chemistry involved, there's physics involved. You know, our mental, emotional, spiritual states are involved, very complex. So, you know, we've had a lot of people that have had full resolution. We've had other people that haven't. One thing that I do say, you know, for sure, is that when you can really understand the relationship that you have with the neuropathy on the environmental level, the physical level, the energetic level, the emotional level, the cognitive level, you have a really good chance of at least getting improvements, whether you get resolution or not. Yeah, but you know, I see a lot of people, it's like even a 30 to 40% improvement is massive. And I actually have a quote that I want to just actually flip back to the top and share. I don't know if I can. Oh yeah, here we go. So healing is not about taking away pain or living symptom free. Healing is about living in the truest essence of peace, joy, and love, who you really are, despite the pain. So if we can come to a place of peace in our system, in our body, to me, that's healed. I might still maybe have some symptoms, but if I can be at perfect peace, I no longer care. And that, for most people that come to see us, that's really, I know what they're looking for, is that whatever has happened has perturbed their peace, has disturbed their peace. And it's about just realigning back with that. So this is our clinic. Here is our website. We actually have a discovery call option that if you're wondering if you might be a good fit for what we do, but you're not sure, you can actually set up a free call with our discovery call team. They'll be able to walk you through, you know, what we do, what we're able to help with. If we're not able to help with what you're dealing with, we have referral lists for you. But that's a really good way for you to just kind of have a call, get a better idea of how we work, and if, you know, your case is something that we might be able to work with. So that was all I'd like to say. Dr. Best, any final words?
No, it's great. Like I said, you know, these cases are complex, but part of what we do is we spend the time with patients to understand all the angles. We look at everything from lifestyle, diet, exercise, stress management, mental health, as well as the physical and physiological components of a disease process and influencing factors. Now, I always tell patients, unless you've had someone who's looked at all those angles for you, there's no telling how much success you can have in your recovery process. You need to look at everything. And so that's why that's what we kind of specialize in. But yeah, we'd be happy to chat some more.
Okay, did you want to start looking at some of the questions, or I know you've answered a few along the way?
Yeah, let's do it. I'll scroll back up to the top here. Okay.
Yeah, Corey, there's one relevant for you here for the, it was a question about would the brain map scans from the CAP show if there's ever any damage to the brain?
Yeah, so we can see indirect behavior of brainwave activity that can point to that. And so, like, one thing that you'll see, for example, is in chronic inflammatory and metabolic state dysfunction states, you can actually get low-grade atrophy where you get loss of synaptic connections. And you will see that show up in certain patterns. A lot of that's repairable now with therapies that we have, depending on the degree. But yeah, you can kind of see indirectly. You can't see definitively though. So you can't say for sure, yeah, there's a structural issue and this is exactly what it is. You can't do that without a CT or an MRI. And that is something that we do a lot with, as well as quantitative MRI, where we overlay the structural and the functional components when necessary.
Yeah. Let's see, next question. So problem with neuropathy of my feet from being a diabetic, feet are warm, cold, burning pain. Is there a cure? Yeah, so diabetic neuropathy, to comment a little bit on that. So again, with diabetic neuropathy, as you're aware, that type of neuropathy, very common with progressive diabetes. Even some patients with prediabetes can actually develop forms of neuropathy. That's not uncommon. The high sugar levels can actually cause some damage and irritation to nerve fibers that can progress. Cure is always an interesting word, right? And cure is that word that we all love and we want to hear. What happens in practice, what I always talk with patients about is, we always shoot for the stars, but if we hit the moon on the way, that's still a good secondary prize. What we shoot for with this, and I can tell you stories, personal patient stories of patients who had mild, moderate, and even severe diabetic neuropathy that now have close to what we would call a cure, where they have very little to no residual neuropathy left in those areas. They're not experiencing pain, their balance and coordination is fully returned, they're able to do the things that they love doing, right? But I have patients on every end of that spectrum. And what we get humbled by in medicine is the complexity of these cases. Any good doctor or practitioner that you see is going to be humbled by what they've seen in practice. And there's a lot we don't know about these conditions. So what we shoot for is, what I always tell patients is, we're going to shoot for, and we're not going to try for anything less. We're shooting to eliminate that neuropathy, get rid of the problem. If we get you 30% of the way there, 50% of the way there, 80% of the way there, or fully there, all of that is marginal levels of success. And we reevaluate it continuously over time. But what I can tell you confidently is, if you haven't tried any of these comprehensive strategies, there is no one who can tell you that there's no chance you can't see improvement. You haven't tried everything.
Yeah, and I think one thing that I'll add to that as well is that it is important, if there's a known contributing cause, it's important to get that under control. So if I was working with diabetic neuropathy, I'm not just going to put you on the laser therapy and, neurofeedback. We have to work to get whatever it is that's going on with insulin signaling or leptin signaling or mTOR. We'd have to get that under control to really have a good shot at reversal. So it's always a two-folded approach of like, work with what's driven it, if there is a known cause that can be isolated, and also work to repair, right? And then that kind of bridges actually into the is it possible to have two types of neuropathy at the same time? Yeah, I mean, it's possible that, absolutely, and it's possible to have multiple contributing factors at once as well. I did see another question further down to that, it could take decades or a lifetime to get everything under control. Well, the nice thing is that everything's connected. We're a quantum processor. So when we work and we get one thing improved, everything else actually shifts and improves, right? Because everything is connected. And that's one of the things that makes things complex, but one of the things that can also make things simple. So, getting mitochondrial function improved can improve everything else. It can improve autoimmune responses. It can improve inflammation. It can improve the ability to regulate emotions. It's you kind of just have to figure out where to start and go from there. So
the next one is, does the mitochondria damage have anything to do with brain fog as well as fatigue? Corey, do you want to touch on that one?
Yeah, sure. Yeah. Actually, mitochondrial damage or mitochondrial dysfunction, one of the first symptoms that tends to come up is brain fog. This is because basically the two areas of the body that are least resourced is the frontal lobe and the gut when we're in a survival state. So if I have limited resources, I can run the gut function at like 20% of what I normally would, and I can live for a really long time in that state. I'm not going to feel very good. I'm going to feel like crap, frankly, but I'm going to be able to live, right? Same with the frontal lobe of the brain. I need this to feel good and to be able to like feel inspired by life and motivated. But if I'm in a survival situation and I'm stuck there, well, I don't really need it to live. I need it to feel good, but I don't need it to live. So a lot of times brain fog is actually a neurological type response, usually of the frontal lobe and the temporal lobe being under-resourced. You also can have blood vessel issues. So you can get capillary hypoperfusion And you can have neurovascular changes, but again, not acute to the point where they're showing up on an MRI or CT, but enough that they're impairing the ability for new synapses to form and for the gray matter in that area to be properly resourced so we can process our reality effectively.
Yeah,
For us,
that
the
actually,
numbers we go with is a normal brain uses 5% of its energy on pain when it has pain, but one who's in chronic pain, like most of us, your brain is now using that higher processing is now using 25% of its energy, and a lot of brain fog comes from that. So if you get that all under control, I think it really helps to bring it down.
Yeah,
Totally.
you have to think of things, our system that kind of ties into that comment is that we have a finite amount of resources to do anything in the body, right? We have energy, and our cognitive system, our central nervous system uses more energy than any system in the body, hands down. And so when it gets challenged by chronic pain, or for example, post-concussive syndrome that can cause inflammation, mitochondrial suppression, or post-COVID syndrome, which we now have copious research on, that a lot of people that are struggling with fatigue and brain fog, it's because of mitochondrial suppression, energy kind of under resourcing. Your brain doesn't have the energy to do the other things like focus, like be able to pull in memories, like be able to do complex tasks. It's a resourcing problem. So part of therapy is about identifying where are we under resourced, what are the roadblocks to being able to build up that resourcing and give your body more energy to be able to do what it wants to do. And so another question, are small fiber and large fiber neuropathy influenced by these listed causes? Yeah, absolutely. Those are, but basically, if you look at the definitions of small fiber and large fiber neuropathy, they're actually not even really a disease diagnosis. It's actually just telling us what types of nerve fibers are being damaged by a process. But if you look up the definitions under that, small fiber neuropathy can be caused by all of the things that we talked about: medications, inflammation, infection. So those definitely fit under those headings that we were talking about before.
There's a question, Dr. Best. Can you repeat what you said about Lyrica, please?
Yeah, so basically what I was mentioning, so with things like gabapentin and Lyrica, these are nerve fiber blocking agents, right? They're neuropathy pain control drugs that primarily work by modulating nerve fiber signaling, right? So if we're getting pain, burning pain, or abnormal sensations, pinprick sensations in a region, Lyrica and gabapentin are supposed to kind of calm down that firing. But the problem with things like Lyrica and gabapentin, and those are useful drugs, we use them in our practice as well. They can be a part of symptom control for some patients. But the problem with those drugs is they do not go after the causes of why you have that neuropathy, right? Lyrica and gabapentin don't fix underlying diabetes that drives diabetic neuropathy. Lyrica and gabapentin and sister drugs can't actually heal damaged nerve fibers. Lyrica and gabapentin can't stimulate new blood vessel growth or nerve repair or myelin repair on those nerves. We have to then, what I always say about those drugs is they're great short-term use cases. But if any of my patients come in and they've been on these drugs for years, or in some cases decades, that's the only treatment they've been given, that is not enough. We need to be looking under the hood to try and find out why is that neuropathy happening, design protocols to go after that, because my eventual goal is going to be, and what most of my patients want to see is, can they actually get to a point where they can come off of those drugs in the long term? We've had a lot of successful neuropathy cases in the clinic where over a period of several months, we're able to actually wean patients off of those drugs long term because they don't need them, because the nerve damage has been dealt with. That's kind of the main comment there.
Okay, now shifting topics slightly to financial, do many or any healthcare plans cover these treatments? AHS, private? Can you just elaborate on that, please?
Yeah, absolutely.
Partially?
So again, our healthcare system, as you're aware, public health covers so much. Typically for naturopathic doctors, there is available coverage. Most people's extended benefits plans, if you have an extended benefit plan, will cover quite a few visits sometimes, or some of the treatments as well. It's actually really individual depending on the healthcare plan that you have. A lot of patients also have things like health savings accounts or health spending accounts through their work. That can be a really good way to access some funding and resources for accessing treatments. And then again, outside of that, typically it does have to be private pay for a lot of these pieces. Some people with injury related cases, we've actually had some success lobbying insurance companies for motor vehicle accident cases, injury related cases. We can actually usually get really significant coverage for a lot of treatments in those cases. We can provide medical letters to kind of get access. We always work, because finances, that's a really important question. We always tell patients finances are a really important part of the conversation as well. Money doesn't grow on trees. Not everybody has large amounts of finances to access for this. That's a really important part of our patient intakes as well. We have direct conversations with our patients. Let us know what you're able to access, and we're going to kind of fine tune and streamline what we can do to make sure that whatever we're doing isn't putting us in a really serious financial situation. We don't want to kind of run into those situations, but there's often some access around that.
Okay, another question. Can you talk to the use of peptides to fight chronic health conditions?
Yeah, peptides is a large, broad topic. Honestly, I'd probably need a couple of hours just to go into that. But peptides are being used more and more in North America to use to try and help with certain types of conditions. So, for example, there are peptides that can be used to modulate inflammatory signaling. There are peptides that can be used to help decrease infection activity and actually slow down the growth of an infection or directly do damage to it or stimulate the immune system. Peptides are useful for some conditions. Peptides are not used for other conditions. So it's just one of the many tools that we have at our disposal.
Okay, a question. Oh, I'm sorry.
So yeah, I was just gonna add with peptides is you just have to be careful with them because there's a lot of like promise behind them. But again, if you're healing tissue, like BPC 157 is really great for, that can be effective long term. But a lot of the other ones, if you're gonna get to a place where you can feel good on them, but if you don't address anything else, you're gonna be having to spend hundreds of dollars every month to keep that up. So it's really, you want to still understand, like, what are you dealing with? What are you really dealing with above and beyond neuropathy, right? Getting deeper below that. So.
And one other comment that came up, I saw another important comment there was this idea. So someone had mentioned that it feels like a red flag for them when they hear full resolution of neuropathy, that it's a bold statement. They've always been told there's no cure. That is an important comment. And what again, why I'm very careful about how I talk about those things. When you heard me talk about that idea of cure, right? I always tell patients, any practitioner who tells you, come into my office, guaranteed we're going to cure your condition, you should probably leave that office and never come back. That person either lacks experience or they're basically just trying to, blow smoke at you and try and convince you that they have some miracle cure for things. That's not really evidence-based medicine. But what I'll tell you is also a fallacy is that I can't tell you how many patients who have walked into my office who have been told by a neurologist or a specialist, this is the rest of your life. There's nothing we can do about this. Just get used to this. I can't tell you how many patients Corey and I have seen where that was what was told to them. We start to look under the hood and we start to address some of these problems and we watch those patients get improvements. Again, getting improvements doesn't necessarily mean every patient is going to be cured. In fact, a lot of patients that we see will not get a full resolution of these symptoms. But if you talk to a lot of my patients who struggle with painful neuropathy, and when they go from 80% debilitated to getting 50% improvement in those symptoms, that can be the difference between somebody suffering, unable to work, spend time with their family, do the sports and activities they love, to actually being able to get some of their life back. That is not something to be discounted. So improvement is a very valuable part of medical care.
Okay, very quick question regarding Lyme disease. What would the prognosis be for people with Lyme disease related to neuropathy issue?
Yeah. Corey, you want to touch on that?
Yeah, totally depends. I've seen a lot of people misdiagnosed with Lyme, for instance.
Yeah.
That's actually related to a mitochondrial related issue. So it's not always Lyme. There depends on how it was tested. There's a lot of different tests out there now. Some of them have a high likelihood of false positivity, especially with immune dysregulation. But in my experience, prognosis is actually really good, provided that there isn't substantial damage that's been done. So it depends. I've seen people that have had they've been paralyzed, and we're not able to reverse the paralysis, and we're not able to reverse the neuropathy. And then I've seen other people that have been 10, 20 years they've been in that state, and you kind of set expectations. We don't know you've been in that state for a long time, and they can get to almost full reversal. So it's not about the Lyme disease, it's about what else is going on along with that.
Yeah.
So
it's a myth that floats around that damaged nerves can't be repaired. That is not true. There are some cases where the damage is so significant that we might not be able to get a lot of repair. That's absolutely true. But it is not an effective blanket statement to say that just because there has been damage, it can never go backwards. We've seen the literature backs this up, the clinical trials back this up. Our patient practices have shown this as well. We typically see varying levels of responses depending on the condition, the patient, and the severity of what's happening. But do not buy the myth that just because there's damage that it's never going to get better. We don't know unless we try. That's the bottom line with these types of therapies.
And then I guess a final question, because I know it's 2:09. Have you ever had patients who've been able to stop taking methotrexate or hydrochloroquine?
Yeah, so that's
hydroxychloroquine. I beg your pardon.
Yeah,
hydroxychloroquine.
Yeah, those are typically used in autoimmune diseases. That's probably, I'm guessing, in relation to an autoimmune condition. I have had patients on every end of the spectrum. I've had patients that with mild to moderate disorders with integrative care, we've been able to actually completely alleviate the need for certain medications like hydroxychloroquine or methotrexate. I have lots of other patients that use those medications, but we've been able to alter their dosages over time. We've been able to lower the dosages, which reduce their side effect profiles. That's the more common outcome that we see. We can modulate the levels of that by often getting better supportive care in so that we don't have as many problems with those medications. There are some cases, but I'll tell you those are rare, where we're able to completely negate the need for autoimmune regulating medications. But that's why integrative care is important. Typically, combination approaches with side effects being a really important consideration is where we get the best results for patients long term.
Okay, and I guess, just one final question. Can you talk to knee pain? Sam is having knee issues that I have constant pain.
Yeah, we have an excellent, he's not present with us today, but we have an excellent MSK sports medicine doctor here, Dr. Nelson. Typically, our approach for any types of joint related pain is we'll have you actually do an assessment with him. He's going to take you through some physical exams, do some really detailed assessment. Then depending on the cause, which can be multiple, right? Could be rheumatoid arthritis, osteoarthritis, ligamentous damage. The list is pretty exhaustive. When we have a better idea of what we're dealing with, then we're going to design protocols and we're going to work as a team to address that.
All right. Well, I think probably you need to get back to your clinic, so we will close this out. Thank you so much for presenting and for taking the time to answer those questions.
Absolutely. Our pleasure. Thank you so much for having us.
And I think
our pleasure.
You'll probably see a couple of visits. I've seen questions about where you're located, et cetera, et cetera, et cetera. So that's good.
Beautiful. That's what we're here for. And even if we can provide guidance as well, just reach out.
Yes, I like that mini questionnaire or assessment tool you have on your website. That's very good. Okay, gentlemen, thank you so much.
Our pleasure.
Thank you, everybody.
Bye.
Take care.
Thanks, everyone.
Bye-bye.
Bye.